remain low in the first phase, or typically the first 4 hours of life, due to what is a common hyperinsulinemic state, similar to what the fetus is exposed to. And then in the second phase, after 4 hours of life, extending to about 3 days of life and then falling off, is the steady upregulation in the production of ketones, specifically beta hydroxybutyrate, which allows for potentially slightly lower glucose levels, because ketones can serve as an alternate energy source for the brain primarily. There are arguments in the literature and even among some of the bigger regulatory bodies, specifically the Pediatric Endocrine Society and the American Academy of Pediatrics, about whether this upregulation of ketones in the first few days of life is either a counter-regulatory mechanism in response to low glucose, or if this is actually a natural adaptation and happens regardless of what the baby's glucose homeostasis status looks like at any given time point in the first 72 hours, and really speaks to more that all babies, knowing that they're going to be somewhat nutrient deficient in the first 72 hours as mom's maternal milk supply gradually increases, that this is an evolutionarily adaptation to that nutrient deficient state in the first 72 hours, allowing for slightly lower glucose levels, but providing an alternate energy source in the form of ketones. And so there's really not a clear indication on whether this is in response to or low glucose, or is the way that ketones are naturally and normally made, if that makes sense. So I wanted to take a minute and talk about defining hypoglycemia, because as a clinician, this is, I think, the thing I struggle with the most in regards to how and when to treat glucose. The literature primarily has used 3 different methods to try to determine what normal glucose is in a given infant at a given time point of life, and they've essentially done it in 3 different ways. They've used what's called the statistical approach, the endocrine response approach, or the neurologic outcome approach. So the statistical approach is simply that. They take a large group of infants and they measure their glucoses over a given time period, oftentimes somewhere between 3 and 5 days. And then they break those normal glucose values down into basically statistical quartiles, or statistical ranges, and basically say that that hypoglycemia should be an abnormal state, and because of that, only a small percentage of infants should be below a given level. And in most cases, they use the 10th percentile. Some studies have used the 5th percentile. The second bullet point here looked at 344 healthy full-term AGA infants. And basically what they decided was that any baby that fell below the 5th percentile in the first few hours of life, well, that had to be statistically had to be abnormal, because it's statistically rare, less than the 5th percentile. So that's the level that we're going to use as hypoglycemia. And so in this case, they determined that in the first 3 hours of life, the babies that fell into the less than the 5th percentile had a glucose of less than 35. And so they published that hypoglycemia in the first 3 hours of life is a glucose less than 35. They did the same at 3 to 24 hours of life, was a glucose less than 40. And then after 24 hours of life, the 5th percentile fell out at around 45. So they decided that these must be the levels for hypoglycemia. So 35, 40, 45. Another study a few years later out of India looked at the 10th percentile and decided that any baby that fell below the 10th percentile was abnormal and had, by definition, hypoglycemia. And in the first 24 hours, they found that that level was 40. And after 24 hours of life, they found that that level was 45. It's interesting because The glucose level that the majority of literature uses to define neonatal hypoglycemia is 47. It's a very specific number, and it's based on the original study from the 1950s. And that study used 47 as the definition of hypoglycemia, and it was based on this statistical approach. And what they said was that based on a group of about 200 AGA term infants, that less than the 10th percentile had to be an abnormal state. And so that 10th percentile fell specifically at 47. The only trouble was that for the next 80 years, all of the future research studies after that, or the vast majority of them, used this 47 number as basically our standard of care. And it's based on a small study, an old study, and essentially a statistical approach, thinking that rare has to be abnormal. And I think that the later studies using the endocrine approach, or what's probably, I think, the most helpful, which is the neurologic outcome approach, I think probably give us better information on truly what neonatal hypoglycemia is. So the endocrine approach looks at, instead of using statistical levels, it looks at specific metabolic data, thinking that if an infant is activating counter-regulatory mechanisms in response to neonatal hypoglycemia, then that specific level must be abnormal. And because if it was high enough, the baby's counter-regulatory mechanisms would not be activated. And several studies have looked at this and tried to define a level based on this counter-regulatory or endocrine response approach. And what Stanley et al. Found was that low ketones, despite elevated fatty acid precursors, suggested limited capacity of AGA infants to synthesize ketones and alternative energy sources. Harris et al. Attempted this as well and found that low ketones and high lactate values in newborns with low glucose levels. The problem with all of the endocrine studies is that the studies are scarce. All of the methods were different, and none of this endocrine response approaches or counter-regulatory approach studies that have been done in the last several decades have come to an agreement on a specific threshold for neonatal hypoglycemia. And so what I think is probably the most helpful approach is looking at neurologic outcome, because ultimately that's what we care about, right? Is not necessarily what level is statistically low or even what level is activating counter-regulatory mechanisms, but what level of hypoglycemia is potentially damaging a newborn's brain. And so there have been several neuroimaging studies that have looked at this, and the first of which found that there was reduced size of deep white matter regions and thinner occipital lobes at 9 to 10 years of age was associated with severe recurrent episodes of hypoglycemia below 47. Lucas et al. Found that glucose is under 47 for 5 or more days in low birth weight infants was associated with severe neurodevelopmental impairments. You keep seeing this 47 level come up that we talked about. And there was also a study that looked at poor executive and visual motor function was associated with a hypoglycemia or glucose less than 47 at 4.5 years. But there was really no difference when they looked. So the nice thing about the CHYLD study was they looked at multiple time intervals. They looked at 2 years, they looked at roughly 5 years, and then they looked again at 10 years of age. And they found abnormal poor executive functioning at 5 years, but no difference at 2 or 10 years. So again, suggesting that maybe this 47 level isn't the end-all be-all of a threshold for treatment of hypoglycemia. I think the best study, although it showed no difference, was the HypoExit study, which essentially compared 2 glucose thresholds for treatment. They looked at infants and treated them for a glucose level of 36 or less, or in the second group, they treated them at 47 or less. And then they looked at them at 18 months and determined if there was any difference between the 2 groups and found no difference. So what they found was there was no improvement in neurologic outcomes if you treat it at a slightly higher threshold, which suggests that this threshold of 45 or around 47 is probably not, does not equate with poor neurologic outcomes, and potentially babies are okay if you use a slightly lower threshold for treatment for hypoglycemia. Unfortunately, that's the extent of the literature that we have now. And so there are no great studies either using the statistical approach, the counter-regulatory approach, or the neurologic outcome approach that have given us more guidance other than this level of 47 that we've been stuck with since the 50s. And thankfully, we've been given some guidance based on combining the statistical approach and the neurologic impairment approach, which I think has given us some idea on when to treat and what glucose targets to treat to. And these are the next two slides I'm going to present here. And what this essentially tells us is that AGA infants are in this top line, on average, have slightly higher glucose levels. They rapidly fall after birth, and then they'll level off and then steadily rise in the first week of life. SGA infants have a similar pattern, but at a slightly lower level. And what the combination of the statistical approach along with the neurologic outcome approach tells us is that likely a level of 45 to 50 or less mandates treatment, and that the target should be somewhere in the 60 to 80 range. As you can see, kind of the red lower levels suggest the necessity for treatment. The yellow middle levels suggest what we call caution, and the green level at the top is kind of your target for treatment. And it's based on this chart here, showing a combination of, this actually combines all of those three thresholds using the statistical approach, the counter-regulatory approach, and the neurologic outcome approach. As you can see here, the levels are kind of delineated. As you can see right around 50 on the left-hand side, they're, the word neuroglycopenic basically means low glucose levels in the brain. This is a level dictated by the neurologic outcome data that we have. The neurogenic responses up a little bit higher, both glucagon and epinephrine and cortisol and growth hormone, uses a combination of all of the counter-regulatory data along with the insulin suppression in that kind of treatment zone at the top. And so what this really is, I think, is a good way to combine the statistical approach, the counter-regulatory approach, and the neurologic outcome approach to guide both a threshold for treatment and a target for treatment, because I think those two things are slightly different. Is where do you start treatment, and then what is your goal for treatment once it's already started? And what it suggests is that a target threshold for treatment somewhere in the 45 to 50 range in an infant in the first 24 hours of life, with a goal for treatment somewhere in the 60 to 80 range in the first 24 to 48 hours of life. And so this is really, because there's been limited data with each approach to defining hypoglycemia, the combination of approaches really has been what has guided therapies. And this is really what I just discussed in those last two slides, or that operational approach. The problem with the operational approach is it still uses what are fairly one point in time levels of a threshold for treatment. And it really, we still don't know how low a glucose must stay low. We don't know how many repeated episodes of low, say for instance, a child is receiving feeds intermittently and we see repeated levels that drop low. We don't know if one level is enough to cause neurologic harm or if it takes repeated levels. And so that still is all stuff that is kind of hard to delineate from the literature. And so that brings us to kind of the two current treatment algorithms that we have in the literature today. The first of which was published by the Pediatric Endocrine Society, trying to help clinicians guide therapy in the first couple of days of life based on this operational approach. Their guidance covers the first 48 hours of life. It relies primarily on neuroendocrine and metabolic data. So again, neurologic outcome and counter-regulatory outcomes. And they suggest that all infants, preemies to a higher degree, have a relatively high levels of insulin at birth, a low ketone, and that they inappropriately preserve glycogen. Basically mean that glycogenolysis is not activated in a normal way compared to children or adults. They suggest, the Pediatric Endocrine Society suggests that a mean glucose of 55 to 65 is both a treatment threshold and a target for treatment, because based on their assessment of the literature, anything below that would be potential cause for harm because of the associated neuroendocrine and metabolic activation of the brain protective mechanisms. And so what the Pediatric Endocrine Society currently recommends is that a threshold for treatment above 50 for infants who are getting feeds, and a threshold above 70 for infants who are getting IV fluids in the first 48 hours of life. The American Academy of Pediatrics, which is what primarily we use here at UMC, took a different approach. They included both fetal and neonatal data into their treatment algorithm, and their ranges for treatment and for both a threshold for treatment and a target goal after treatment has already been started is considerably lower than the Pediatric Endocrine Society. The other interesting point is that the American Academy of Pediatrics argues directly against the Pediatric Endocrine Society's assessment of ketone levels in the first 24 hours. And like we talked about earlier, the American Academy of Pediatrics feels that the elevation of ketones in the first 24 to 48 hours of birth in normal breastfed infants is not actually a counter-regulatory mechanism, but a normal adaptation, allowing for infants to have an alternative source of energy for their brain in the early postnatal period, knowing that the amount of breast milk availability in that period is going to be low. And so it allows them a source to keep, to allow their brain to stay active and give it the energy it needs, without having to activate other counter-regulatory mechanisms. So the American Academy of Pediatrics feels like the elevation of ketones isn't a counter-regulatory mechanism, it's a normal state. And that the higher levels that are used in the Pediatric Endocrine Society of 55 to 65 based on this elevation in ketones is not actually indicative of neonatal hypoglycemia, justifying the lower thresholds for the algorithm for the American Academy of Pediatrics. And so this is what the American Academy of AAP's algorithm looks like. I'm sure we've all seen it. As you can see, there's considerably lower thresholds for treatment in the first 48 hours of life. They argue that all infants, all asymptomatic infants, should be fed within an hour of life, and that a glucose should be taken within 30 minutes of that feed. I would argue that typically pre-feed glucoses are best to guide therapy because they are likely the lowest level that the glucose will fall to, and the moments when the children's brain are at risk most for being damaged by hypoglycemia. So, but after that initial feed, obtaining a glucose 30 minutes later, and if the initial screen is less than 25, they argue that the child should then be fed immediately, and the glucose should be checked in an hour. Any glucose after that, less than 25, would require IV glucose therapy. Any glucose in the 25 to 40 range would either require a refeed, an immediate refeed, or IV glucose as needed. The threshold slightly increased from 25 to 35 after 4 hours of life. And again, that threshold of 35 is used for necessitating treatment with IV glucose. And that range of 35 to 45 is when you could consider refeeding versus using IV glucose as well. I think the the biggest takeaway from both the current treatment algorithms from the AAP and the Pediatric Endocrine Society is that these are not based on robust, reliable, long-term data. These are really based on the best available evidence, which is arguably limited, and expert opinion, understanding that the thresholds for neurologic impairment from neonatal hypoglycemia are likely going to be lower than what is necessary for treatment, but I would argue that's a good thing. I would argue that I would rather treat a kid a little bit more aggressively and maintain their glucoses at slightly higher levels so they're never even close to being at risk for a neurologic impairment from neonatal hypoglycemia. Simply put, I would argue for overtreatment versus undertreatment, and knowing that that may necessitate separation from mom and may interrupt the establishment of good breastfeeding. And so I think it's always a fine balance, one of which I don't feel like I have a great feeling for is when do you justify separation of mom and interruption of breastfeeding to treat glucose? But I would argue that overtreatment is probably the goal. I think undertreatment probably places more infants at risk for neurologic impairment from neonatal hypoglycemia. I think we all are aware of the risk factors for neonatal hypoglycemia, but I just wanted to go through them again. So any symptoms of hypoglycemia? Symptoms of hypoglycemia is tricky because infants can't often tell you that they are feeling weak or they are feeling tired. And so it is oftentimes hard because the most common symptom of hypoglycemia is lethargy, but infants sleep for the vast majority of the day. So I think it's difficult to base treatment on clinical symptoms alone. I think jitteriness may be a helpful symptom, but again, there are other reasons that can cause jitteriness in infants. So it's a tricky way to treat infants based on clinical symptoms alone. I think we all know that a large for gestational age infants are at risk, and I have a slide that kind of goes through that reasoning. The one that we don't often think about, and I have to oftentimes remind myself, is that any infant exposed to perinatal stress is at risk for hypoglycemia. So things like birth asphyxia, ischemia, even simply a cesarean section delivery for non-reassuring fetal heart tones, maternal preeclampsia, or even maternal hypertension can cause perinatal stress, altering glucose homeostasis, growth restrictions, so SGA infants, and then things like meconium aspiration can alter glucose homeostasis, prematurity, infants of diabetic mothers, which oftentimes ties into the large for gestational age infants, and then some of those rare congenital syndromes, specifically Beckwith-Wiedemann, that will oftentimes present with neonatal hypoglycemia specifically, and then later in life with a large tongue, hemihypertrophy, some other specific findings indicative of Beckwith-Wiedemann. So treatment, I'll talk about briefly. So breastfeeding, really feeding and specifically breastfeeding as early as possible are the goal to prevent neonatal hypoglycemia, not only to potentially provide some colostrum or even some glucose to the infant, but actually just to reduce stress, which can improve glucose homeostasis. And it's currently recommended to keep the intervals between feeding short, somewhere between 2 and 3 hours, and then potentially supplemental formula feedings for preterm infants, SGA infants, LGA infants, infants with born to mothers with poorly controlled diabetes, and then specifically NICU infants. So I wanted to touch base about infants of diabetic mothers briefly, again, just to go over the underlying mechanism that causes it. So again, glucose crosses the placenta, but insulin does not. And so really what causes an infant of a diabetic mother to become hypoglycemic after birth is the upregulation of fetal insulin production due to consistent and long-term exposure to hypoglycemia in utero. Following delivery, the birth removes the source of glucose, of elevated glucose that balances out that upregulation of fetal insulin. But the postnatal infant who has elevated levels of fetal, or when they were fetuses, had elevated levels of insulin, the insulin levels remain high. And it takes oftentimes days, even sometimes weeks, for that insulin level to normalize. And so you essentially have a state of high insulin levels, but low glucose delivery, and so the glucose plummets. And the other problem with that is that because of the elevated insulin, gluconeogenesis is inhibited. And so you have a state of high insulin, low glucose delivery, and a lack of activation of the counter-regulatory mechanisms that may increase or normalize the glucose in that infant, specifically gluconeogenesis and glycogenolysis, which are both inhibited by insulin. And so you create a state where the baby has high insulin, low glucose, and no way for their body's own counter-regulatory mechanisms to correct that low glucose. Some other kind of treatment points about hypoglycemia. Safe skin to skin can reduce stress and help to normalize glucose homeostasis, maintaining temperature. Really, the way I think about this is anything that can prevent excess increases in basal metabolic rate will help to normalize glucose or prevent the treatment of hypoglycemia, because we know that any forms of stress, any other reasons for an increased basal metabolic rate will use glucose and potentially expose the child to hypoglycemia. And I think one of the bigger takeaways from this really is that any guideline that a hospital uses should allow for rapid escalation of treatment when indicated to reliably prevent severe and persistent hypoglycemia. I think it's less important the specific thresholds that a hospital or a physician group decides to use, and more important that the treatment approaches are consistent among the providers and the group, and that when it is determined that a child truly has neonatal hypoglycemia that needs treatment, it's rapidly treated and the glucose is brought back to goal. I think the threshold is less important than really rapid correction of low glucose, regardless of what threshold is used by your team. I did want to and just go over this quickly. I think everybody is aware of kind of how to treat hypoglycemia. Again, any low glucose that is felt to be in a concerning range indicates an immediate IV glucose bolus of 2 mLs per kilo of D10. And then the initiation of a continuous infusion of D10 for a glucose infusion rate of goal of 5 to 8 milligrams per kilo per minute. This is the way that I quickly calculate GIR, and I try to do this on every baby that we start fluids on to ensure that we're within range. And if you just take the dextrose percentage, so D10 is 10, the rate would be, in this example, 12. A 3 kilo infant, it'd be 10 times 12 times a constant of 0.167 divided by 3, or in this case, so a 3 kilo infant on D10 running at 12 mLs an hour, which is roughly 60 per kilo, would give us a GIR of 6.7, right in the middle of range. And then I did want to touch really quickly on dextrose gel. I think one of my best sources of evidence is the neonatal Cochrane database. This is a study that's been updated now twice, looking specifically at oral dextrose gel for the prevention of low blood glucose. Unfortunately, I think we were all hopeful that this data would come out to be slightly more positive than it was. But what the Cochrane says about dextrose gel is there are two well done studies looking at 2,500 infants, both in high income, so developed nations, who have outcome assessments in newborns at 2 years to 6 to 7 years of age, who were treated with glucose gel in the neonatal period. They do suggest that oral dextrose gel is safe and effective in reducing neonatal hypoglycemia, so in improving blood glucose levels, but they are uncertain whether oral dextrose gel actually increases or improves neurodevelopmental outcomes. And specifically what they said is that the evidence from the two studies suggests that oral glucose gel is safe, but one of the big takeaways from the study is that there was really no improvement between the oral dextrose gel and placebo in reducing the need for treatment for low blood glucoses with IV infusions of glucose, and that the use of an oral dextrose gel protocol may have little to no effect on separation from mom for treatment of hypoglycemia. But there was a lot of variation between those two studies, and they weren't able to look at breastfeeding. And they also, the trouble with the studies is that one of the studies showed an improvement in neurologic outcomes in the placebo group or in the dextrose gel group. The trouble is the other study actually showed that neurologic outcomes were better in the placebo group. And so although it may increase glucose levels, it's still unclear whether dextrose gel prevents the need for IV glucose therapy, prevents separation from mom, and improves neurologic outcomes. So I think ultimately the jury is still out on dextrose gel. If you are interested in dextrose gel, though, there's a nice kind of explanation on how to do it here, because it works best when done in a very specific way. Specifically, the inside of the buccal mucosa has to be dry for the gel to absorb quickly and efficiently. And so this is just kind of a nice picture explanation on how to do it. And then probably the best of algorithm I could find. We are not currently using this in our NICU, but this is the one that it seems like most places who are using it come back to. And so I wanted to provide that for everybody, and that you're interested in using glucose gel or adjusting the way that you use it currently. And that is the last slide I have. I would love to answer any questions anybody has, or anything that anybody else would like to discuss or bring up, or something I missed, or something that your group is doing that you found helpful. So I kind of wanted to open it to the group for further discussion.
Again, thank you, Dr. Searle, for your presentation. It was great. I will post in the comments the link to the evaluation, if you guys will fill that out. And then I will get your CNE certificate to you later today. I really appreciate everybody taking time this morning to join us. And as always, please feel free to extend any suggestions for education that you have, any needs that you're seeing specifically, and we can certainly tailor our education to you and your facility. So this will occur again in January. We will probably have a presentation from our pediatric group, just again on different respiratory illnesses. We're still kind of working out the final decision on that. So if you have anything that you're specifically seeing, feel free to give that to me, and I will share that with our pediatric department. But again, thank you guys for joining us this morning, and thank you, Dr. Searle, for your presentation.
Of course. Thank you, everyone.
Have a great day.